Bismillahirrahmanirrahim. Assalamu alaikum. Welcome. Now, today we will discuss very important topic. Previously, we discussed the Cushing syndrome, and that was the hyperactivity of the adrenal gland, adrenal cortex, and others. And today we discuss the problem of the underactivity. That's called Addison disease. Addison disease was described Thomas Addison in 1855 is a adrenocortical insufficiency due to the destruction or dysfunction of the entire adrenal cortex. Most of the times, both adrenal this cortisol and aldosterone, they are decreased. Now, this occurs slowly in most of the cases. So when the 90% of the adrenal cortex is destroyed, then the patient develops signs symptoms of the Addison disease. There are two presentations. One is the primary chronic adrenal insufficiency, and the second is acute adrenal insufficiency. That's the emergency conditions, primary, and second is slowly. So now the causes, you go for most of the times we found the idiopathic autoimmune. We cannot find what could be the reason, and there is slowly destruction. This is a common cause of the adrenal gland involvement, and mostly the adrenal cortex is involved, while adrenal medulla is spared. And maybe some other autoimmune disorders in association with Addison disease are present, like celiac disease, like diabetes type 1. They may be associated with this, and hypothyroidism. This is the Addison disease. So sometimes symptoms are, mixed. Initially difficult to diagnose. This is really the Addison disease, which is the predominant problem, especially in idiopathic autoimmune disease. Second is common tuberculosis. The tuberculosis directly does not involve. Definitely, there will be some sort of the evidence or history, the pulmonary tuberculosis, abdominal tuberculosis. Then it can be involve the adrenal glands. Sarcoidosis, streptolasmosis, blastomycosis, cryptococcus. These are infiltrative disease and cause destruction slowly. Malignant infiltration from other areas or direct, and then the metastasis, malignancy, the amyloidosis, hemochromatosis is not so common, but it may be considered. AIDS, some drugs can destroy, and abdominal radiation due to the malignancy of the abdomen, especially the lymphomas. Although they use the protective measures, but even in spite of that, patient can have this problem. Now, if you go for the clinical features, now I told you that it may be alone sometimes. Addison disease may be associated with other autoimmune disorders. So initially, the symptoms have no specific, because cortisol is decreased, aldosterone is decreased. So patient usually have symptoms of the hypotension, hypoglycemia, slow, weakness, lethargy, vertigo due to postural hypotension. And second important thing which occurs here is it's very important point that for the formation in the adrenal medulla, adrenaline, cortisol is essential. If the cortisol is not present, then the formation of the adrenaline and noradrenaline in the adrenal medulla is decreased. That's why in these patients there is a decreased heart rate and also blood pressure is decreased, but the specific sign is the postural hypertension. Postural hypertension can be seen in other autonomic dysfunction. There are so many diseases, diabetic neuropathy, and Shire-Duggar syndrome, in which you can see the postural hypertension. So it's not a specific 100%, but if with other signs and symptoms, if this is present, you may think about the Addison disease. Now, Hyperpigmentation of the skin and mucous membrane. This occurs when the primary cause is there, and CTH is secreted continuously from the pituitary and MS, melanocyte stimulus hormone. They're both secreted from the pituitary, and they are not stopped. There is a continuous overflow or excretion. So this causes the hyperpigmentation of the different areas. So the stimulate to the melanocytes and causes the blackening of the different areas, especially the persons who are fair skin, they can easily see, but even in the dark skin person, you can also be visible because there is history that the पहले इतना काला नहीं था, अब ज़्यादा काला हो गया है, लेकिन there are specific areas should be looked for that for pigmentation, recent pigmentation, especially the creases of the palm and nail beds, mucous membrane inside, and even the lips, and especially the gums, knuckles, elbows. So these are the areas where even and the nipples, nipples more darker, and it's present the scars and pressure areas, especially where you belt or other things which you tight. So you will find that there will be more pigmentation, blackening. So recent onset of pigmentation or darkening the skin, you may think about that maybe suffering from the Addison's disease. Then in autoimmune disorders, you will find the vitiligo. This is the white patches of the different areas of the body, white patches. This the autoimmune. There are other reasons also, but this is a more marked, generalized vitiligo. So this may be the reason that if there is on the one hand there is hyperpigmentation, on the other hand there is the vitiligo. Both are present. That is very suggestive of Addison's disease. Progressive weakness. Because there is electron imbalance, there is hyperkalemia, hyponatremia, and also the muscle weakness, blood sugar is decreased, blood pressure is decreased, high cardiac output decreased. So usually patients feel fatigue and weakness. Proximal myopathy is very much common. So fatigue, progressive weakness. Poor appetite is decreased because steroid stimulates the appetite. So usually there is weight loss, poor appetite, nausea, vomiting, sometimes diarrhea, unexplained diarrhea with weight loss, and hypertension, especially the postal hypertension. You may think about Addison's disease. The dizziness definitely because of the postal hypertension. I hope that you might be knowing how to check the postal hypertension. check that. Muscle pain and joint. Check it. Myalgias, muscle and joint pains. And in males, there is the impotence, and in females, males impotence and decreased libido, females amenorrhea. So these are the problems which can be seen in many other diseases, but also, these are all symptoms may not be present, but few important symptoms which are the pigmentation, maybe vitiligo together, hypertension, weakness, lethargy, diarrhea, and so joint pain. These symptoms, weight loss, especially weight loss is very important. Thin people, they are thin, lean. Now you can see here in this picture the generalized skin pigmentation, but occasionally the deposition in the former skin increase the nails and gums. You can see here the present. She was treated many years ago for TB. So this may be the tuberculosis of the adrenal glands. Now here the buccal mucosa inside the black, and again the gums. So this is the white patches, vitiligo. So this is not specific, but suggestive of Addison's disease. And important hair loss and also the pigmentation you can find in the back of the neck, axillary. The hair loss is important. Pubic hair loss, axillary hair loss is very important. So they should be looked and asked. That's very suggestive of in these other symptoms. If hair loss is there, then it may be suggestive of Addison disease. Now, basically, what happens? Why this occurs? So, what happens that pathophysiology, the adrenal glands not functioning because of any reason. We discussed the causes. Then what will happen? There is decreased secretion of the aldosterone. Adrenal cortex are not working basically here. So, aldosterone is very low or absent. And if you go with the cortisol, cortisol may be converted in peripherally hydrocortisone, cortisone acetate, prednisolone, or dexamethasone is very low or absent. Now, cortisol is low, then liver function decreases, stomach enzyme decreases. Liver function decreases leads to the low sugar, and extremely low sugar leads to the symptoms of the hypoglycemia, weakness, sweating, palpitation, and sometimes fits and unconsciousness. Now, stomach digestive enzymes are decreased leads to vomiting, diarrhea, and cramps. And this leads to the low fluid volume, dehydration, hypotension, and shock. Now, aldosterone is basically the hormone which causes the retention of the sodium and potassium excretion and maintenance of the blood pressure. So what here, the kidney tries water and sodium is lost. There's hypotension, low blood pressure, it becomes irregular, small, and output decreases. Because of the output decreases, there is low blood pressure and also the low blood volume because of the vomiting, diarrhea, and both can lead to the shock, and shock can lead to the initially maybe fits, restless agitation, and then coma, and finally death. So from this you can see how once the crisis begins, it begins to affect vital organs. The sooner you can see your injectable and relative fluids, the sooner you can say the provocation. Now this is the additional, basically the crisis, how it occurs. So this crisis is overcome, can be treated with injectables, not oral. It's very emergency. Now when you suspect Addison disease, you have to go for the certain investigations. Now, important investigations, because most of the time this is primary, but sometimes it may be the CT secreted from. This is primary adrenal problem. So, what first we establish there is a recent disease. So, go for the SCTH level, cortisol level, especially the early morning is advisable, and SCTH stimulation test, synaxin test, in which the synthetic SCTH is given 0.25 milligram, and after 45 minutes, the cortisol is checked. Normally, it should raise, but here it is not raised because adrenal gland is not working. So these are three tests which are important. Now, other tests will suggest that is the blood CP. You will find the relative lymphocytosis, eosinophilia, and neutropenia, and electrolytes, hyponatremia, and hyperkalemia. So these are the blood urine nitrogen raised because of dehydration. This also should be helpful. The urinary and sodium sweet is elevated. You can advise also to see there is the hyponatremia. Why is hyponatremia? Because excretion and the BUN, blood urine nitrogen elevated, creatine was elevated, sugar is low, and chest X-ray you'll find small heart, lungs are normal, ECG will low voltage. Now low voltage can be seen in other conditions like hypothyroidism, especially. So both conditions can occur together, hypothyroidism and Addison disease. I told you it is called Semmet syndrome, in which there will be low voltage ECG, hypotension, and bradycardia. Now, if you go for the treatment, because treatment is lifelong. Once Addison disease is diagnosed with because 90% is destroyed, adrenal gland. So it is difficult to make it more. Regeneration is not possible. So you have to go for the replacement of the cortisol, and if needed, aldosterone. That is, synthetic corticosteroids are given So if the patient is not an emergency, the patient has chronic problem, so you have to give prednisolone daily or in the divided doses. So if you dose is 5 to 7 milligram daily, so you give single dose daily in the morning or 5 milligram in the AM morning and 2.5 milligram at the afternoon 4 to 5 p.m. And this dose is universal. You will feel the patient will improve, his blood pressure will improve, appetite will improve, well-being will improve. And if the patient sometimes becomes ill, stressful situation, for surgery, the dose in pregnancy, 50% dose is increased. So this is some situations where you can go for, and then again the patient becomes normal, then you have to decrease the dose. Now, if in spite of giving the prednisolone and it blood pressure does not increase or patient develops still the vertigo, dizziness, then you have to give fludrocortisone, that is the synthetic aldosterone. So that should be given 0.05 to 1 milligram OD, and that is sufficient to raise the blood pressure. And this is also lifelong treatment for this. Now, additional crisis, if the patient has presented with additional crisis that I told you the patient can present with acutely, which is severe disease like diarrhea, vomiting, fever. So this can occur due to some stressful conditions. When there is infection, there is a trauma, accident, or there is surgery, patient previously was not diagnosed, or patient was diagnosed but he was not given attention, then patient can develop additional crisis. So in that situation, we have to give injectable 100 milligram hydrocortisone in 100 cc of the normal saline. And unexplained hypertension, when the patient does not have blood loss, obviously patient does not have a history of infection or fever, is not febrile, you may think about the steroid problem. So in that situation, we have to give the 100 milligram if it is not diagnosed. But if diagnosed, definitely we have to give this therapy. So 100 milligram hydrocortisone in 100 cc normal saline, 10 to 12 ml per hour, okay? Or 100 milligram of hydrocortisone bolus every 6 to 8 hours, and see the condition. At the same time, you can give, if the glucose is low, you can give glucose, you can give the IV fluids and antibiotics if the patient is needed. Now, patient is stable, then you can put patient on the oral therapy, which we have discussed. Patient education is important. Just we give education to the diabetic patient that you have, the patient who is hypothyroidism, that you have to give this medication for whole life. It is very important. Patient should take medication for whole life. Patient should wear an emergency medical alert bracelet, because sometimes patient doesn't know, patient is unconscious, he becomes accident, he has accident and brought casualty. Then how we come to know that patient suffering from this? So in other countries, they usually advise medical alert bracelet. Patient should be instructed double or triple their steroid replacement doses in stressful situations. This is also important. He should consult doctor, or he can increase the dose, and then stress will over, he can bring dose back the pre-problem disease. There's another important topic which we see the clinical practice as the CONN syndrome. Actually, it is characterized by increased aldosterone secretion from the adrenal glands, suppressed plasma renin activity, hypertension, and hypokalemia. These patients usually present with resistant hypertension. It was first described in 1995 by the W.J. CONN. Now, when some patients taking 3 drugs, in spite of their blood pressure is not under control, you may think it is called resistant hypertension, and you may think about the CONN syndrome and should be investigated. So in 3 drugs, 2 maybe whatever other groups, one group, one drug should be diuretics. So 3 drugs, patient is not under control. And if you go for the investigation, you will find that plasma renin is suppressed. Patient has hypokalemia, then you may think about aldosterone secretion and go for further investigations. Causes: the unilateral aldosterone producing adenoma, bilateral adrenal hyperplasia, or idiopathic hyperaldosteronism. These are the causes of three very important causes: unilateral aldosterone tumor, bilateral adrenal hyperplasia, or idiopathic hyperaldosteronism. Idiopathic, we don't know what's the reason. Clinical features: because there is hypernatremia. You know, in the Addison disease, there is the hyponatremia and hyperkalemia. But here is the hypernatremia, hypokalemia, alkalosis. Now, hypokalemia, you will see hypertension is because of the increased sodium, and the weakness is because of the hypokalemia. And this weakness, fatigue, and alkalosis is there, metabolic alkalosis is there. So fatigue is an important symptom, and the blood pressure is high. Raised, especially systolic blood pressure. Both are raised, but more systolic. Fatigue, muscle weakness, cramping, headache, palpitation because of increased hypertension, polydipsia, polyuria, hypertension. So these are the important things, because of it has been seen that those patients who have resistant hypertension, 30% patients from them were suffering from the CONN syndrome. So this is a treatable condition. So it's not you adding more and more drugs. You try to find why the patient is not responding. If the patient is compliant is good, he takes all medications properly. In spite of that, this blood pressure is not under control. Then you may think about CONN syndrome. But it's very important that compliance should be checked first, because most of the times when we give polypharmacy, 2-3 drugs, patient usually stop and does not take drugs properly, or sometimes drugs are costly, so they don't take properly, and they either decrease the dose or you go for alternate day. So compliance is important. Then you go for this. You had advised the serum renin level. It is suppressed, and electrolytes, I told you the hypernatremia, hypokalemia, because aldosterone causes the retention of sodium, aldosterone potassium loss. Blood sugar usually is normal. CT scan of the abdomen that shows important, because sometimes MRI of the abdomen can be done that shows the adenoma, and it is, for example, inconclusive. Then you can go for the scanning with iodine 131. So that's very important investigation, and that should be done before rule out any malignancy or other things. MRI can be done. Okay. These are investigations which we will advise. Aldosterone can be advised. Urinary aldosterone can be seen. This is also important test. Important here is the renin, because renin is important here. Renin should be suppressed. Now treatment. Treatment is usually surgical, but sometimes we can give also medical things. First, the blood pressure control of hypertension and electrolytes, and then the persistent hypertension, because mostly surgical, because there is adenoma, so you have to remove it. Otherwise, medical treatment only will control the blood pressure, but disease will progress it. So the curative treatment surgical, but for any reason the patient is not fit for surgery. If the patient does not want surgery, then we have to do option is the medical treatment. Medical treatment control hypertension, electrolytes. If the patient has persistent hypertension post-operatively, then definitely we have some patients, unfortunate patients, they develop persistent hypertension. So we have to give this therapy, but definitely dose decreases. And poor surgical candidates for other problems, not fit for surgery, reluctant for surgery, then you have to go for the medical treatment. So they refuse surgery. So what you do is sodium restriction, potassium sparing diuretic, spironolactone should be given. This is a drug of choice. Even the patient, if you're not able, the potassium supplement should be given. Even if you're not able to pick, initially you have doubts you have to add the potassium sparing diuretics. You will see the dramatic response. That also confirms that your diagnosis is correct. So these are the things which has to be done for these patients, and definitely outcome is good. So proper investigation is important, and then you have to go for the surgery or the medication. Medication is lifelong. Remember this. Thank you very much. Going to stop.